Hello, everyone. Thank you for joining us this morning. My name is Josh Mann, and I'm the Director of Engagement and Outreach for the VHL Alliance. So today, I'm excited to welcome Dr. Eric Jonasch, who will be speaking about updates in VHL research pertaining to HIF-2alpha inhibitors. Dr. Jonasch is a professor in the Department of Genitourinary Medical Oncology in the Division of Cancer Medicine at MD Anderson Cancer Center at the University of Texas in Houston. Since 2003, Dr. Jonasch has been the director of the VHL Comprehensive Clinical Care Center at MD Anderson. He is also the chair of VHLA's Research Council, Clinical Advisory Council, and Clinical Trials Task Force. Dr. Jonasch is also a lead investigator in the MK6482 clinical trials, formerly known as PT2977. Dr. Jonasch, thank you so much for joining us today.
Josh, thank you, and thanks to everyone for being on this morning. And what I wanted to do is I wanted to talk about the results of a clinical trial that we've been doing with MK6482 or PT2977, which we presented at the American Society of Clinical Oncology meeting last weekend. And many of you, I think, are already familiar with this compound, but in brief, what this is it's a HIF-2alpha inhibitor. So what is HIF-2alpha? HIF-2alpha is a protein, a transcription factor that is inappropriately increased if you have broken VHL or mutated VHL. And because of high levels of HIF-2alpha, you end up getting production of a large number of factors that one shouldn't be producing on a regular basis, which results in the formation of VHL-related tumors and also the characteristics of these tumors, which mean that in terms of the blood vessels, that there are many blood vessels around hemangioblastomas and kidney cancers, for example. So this drug, MK6482, what it does is it basically jams into HIF-2alpha proteins and prevents HIF-2alpha proteins then from doing its job of then transcribing other genes. So this study was a 61 patient study, so 61 individuals who had germline confirmed von hippel-lindau disease received this drug. It's given by pill daily. And the primary endpoint of the study was to look at shrinkage of kidney tumors. Now, the large majority of individuals in this trial also had hemangioblastomas, and there were a number who had other VHL-related manifestations. But the trial, whenever we design a trial, what we have to do is we have to have sort of a statistically tenable sort of endpoint, it's called, meaning you have to be able to say, you know, here's what we think it's going to do, and it's going to be able to do that in X percentage of people. And that's the sort of thing that allows you to get FDA approval eventually. So this study, basically 61 people were enrolled. We looked at shrinkage of the renal cell carcinomas and other areas in the body. And we also looked at toxicity and a variety of other endpoints. Just in terms of, you know, who was on the trial, the median age of individuals was about 41 years. It was pretty even split between men and women. 90% of people had had some kind of prior surgery, of which about 50% had had some kind of prior renal cell carcinoma. As I mentioned before, 80% had hemangioblastomas, and about half had some kind of pancreatic lesion, and about a quarter had hemangioblastomas in the eye. So the primary endpoint, which I mentioned before, was this shrinkage. So what we call shrinkage in clinical trials is a minimum of 30% reduction. That's called by this measurement algorithm called RECIST. That's called a partial response. The other thing that we look at is we look at whether or not this response is confirmed or unconfirmed. Confirmed means you see it on 2 subsequent scans. So the trial showed that 28% of individuals had a confirmed partial response in the kidney tumors, meaning a minimum 30% shrinkage. Another 13% had an unconfirmed partial response. And just by virtue of what we've been seeing with this compound, we're expecting that all of those unconfirmed are going to become confirmed, and probably more are going to become partial responses. So over 40% had some kind of shrinkage. Put in another way, if you just look at any percent shrinkage, like what percentage of individuals had some kind of decrease in their kidney tumors, that number was 87%. So the large majority of people had some degree of shrinkage in their kidney tumors, and only very, very few people had any kind of growth, and nobody had significant growth whatsoever. Almost everybody is still on the drug, meaning that this is something that has a duration, durable benefit. This is not just a flash in the pan kind of response, so that's very nice. We also did some evaluation looking at whether or not, the other question or concern is, well, maybe this is something that, everybody's tumors were pretty stable and this wasn't really, a true effect. But we looked at the growth rates of the tumors that we looked in the kidneys before the treatment versus after the treatment. And we clearly saw that there was a very well-established growth rate, a rate of increase of these tumors before, which is kind of like duh, because they weren't there at birth, so they had to have started sometime. And then there's a very nice shrinkage after initiation of treatment. Side effects are obviously a huge deal, because if you're going to be on some kind of a therapy for a prolonged period of time, you have to have reasonable quality of life. And maybe some people on the call have been on some of my sunitinib or pazopanib trials. I mean, these drugs, they do provide benefit, but they also provide a lot of side effects, and to many people, the degree that they are not necessarily acceptable. In this study, we saw that there was a rate of anemia, which is an expected side effect, because the development of EPO or erythropoietin, which is what makes our red blood cells go up, is actually blocked by this. But that was fixed by giving basically EPO shots. And there was a little bit of fatigue and a little bit of a small percentage of people who had what was called hypoxia, meaning that the oxygen levels in the blood were down a little bit, but not to the degree that it was actually causing any symptoms. So well tolerated. We saw that there was shrinkage in hemangioblastomas, and we don't have a formal analysis yet, because just in terms of us getting the scans and looking at these formally, we weren't able to get that together for this particular Congress, but we're probably going to have those data by the time that we're going to be presenting in the next congresses and publishing these data. And we're seeing that hemangioblastomas are shrinking fairly consistently across everyone. So in conclusion, this is a fairly well tolerated drug that people can take for a fairly continuous period of time. It clearly demonstrates, and we've formally shown this, shrinkage in kidney tumors. We have early data suggesting that this is causing shrinkage in hemangioblastomas. So what's next? We're obviously, I personally, sort of as a doctor who's involved in caring for individuals with VHL, I want this to be approved by the FDA, but there's a process now. So these data are going to be presented to the Food and Drug Administration, the FDA. There will be an assessment made, and this is all going to be done by Merck, who now owns this drug. And we're going to have to see what the FDA says. And again, me personally, I really want it to be approved. We're going to have to see whether the data are strong enough, and we'll find out probably within the next by the holiday season. We'll probably know what's going to happen there. What else could we possibly do? Well, there would be potentially other clinical trials. Maybe for prevention. So, you take a group of young people with VHL and see whether or not by giving this drug, we can prevent the development of hemangioblastomas. And obviously moving forward, there could be some other kind of studies looking at combinations with other therapies. So I'll stop there. I mean, that's basically what the study that we presented at ASCO last week showed. Super excited about it and happy to answer any questions.
Dr. Jonasch, thank you so much. That's such exciting news, and thank you for this update. We have a number of questions. What do you think moving forward? What do you think the timeline might look like as far as presenting to the FDA, and then ultimately, when do you think patients would actually be able to, um, get this medication prescribed to them?
Right. So again, there's a lot of ifs and in my answer, but if this particular study is considered to be sufficient evidence for approval, then I would expect that this would potentially become available by late 2020, early 2021. If the FDA says, great first effort, we love you guys, and now go do another trial or add additional patients, then that additional study that new study would be probably then launched in that same time frame. So those would be the two sort of, I think, realistic scenarios. I mean, the third scenario of them saying, guys, just give up, don't try developing this drug further. That's an unlikely scenario. So I think we have one of two scenarios. One would be that, we would have what's called accelerated approval. The other would be that we would go back and we would be asked to generate additional data. It's probably going to be an and thing, where we're going to be told, you're yes approved, and you need to do additional studies. And then, the question then would be, what would those studies look like? Would we, the idea of randomization for people who have existing, spots in their body already from VHL really kind of, makes me very unhappy. So we'll have to see what we can do from a design perspective.
We have lots of questions for you, Dr. Jonasch. A question here is, if it goes to the FDA for approval and they choose not to approve it, would that effectively end the trial?
Yes. I mean, if they were to, well, they could request, they could say, these data are promising, but you need to generate more. And what that would do is it would end up then resulting in additional trials being opened, where we would be gathering additional information, and that would, and it's a realistic and possible scenario. It's not what I want, but I think we have to prepare ourselves for that possibility, because I don't want to, what we don't want is what we hope for, and I think this is kind of living with, working with people, living with this. We have our hopes, and we also have to manage those hopes. So there is a possibility that they're going to say that we need to do additional studies, and I would imagine that if we had to do that we would be able to get those accrued to, meaning those studies filled and done pretty quickly. But it would push things back. It would push things back by at least a year.
In your research, or also if the drug is approved, is there an ideal age range for patients that the drug would be ideal for, or that it would even be approved for?
So interesting question, because this hasn't really been the question of whether there's going to be a lower limit of age will be an interesting one, and I think we'd have to work that one out. I mean, because the way that drugs are metabolized in younger people, meaning kids and teens versus grown-ups after the age of 18 and older, is sometimes a little bit different. And so there would have to be sort of a discussion about that. I'm hoping that we would be able to get, that there wouldn't be some sort of a lower age limit, and that would obviously be very difficult to enforce practically anyhow. But right now, with regards to whom should, based on the evidence we currently have, who should get this if we were to get it approved, it would be people who have I would say either a renal cell carcinoma, a pheochromocytoma, a pancreatic, a pancreatic neuroendocrine tumor, a hemangioblastoma. That looks like it's potentially going to cause trouble in the next year or so, and we want to prevent it from getting to that point. Starting this before we actually start, having issues, and preventing those issues from arising.
Do you know if for patients who are currently in the clinical trial, what would it mean for them if the drug either was approved or if it went back for another phase for the trial?
So for people who are currently on the study, it would not affect their participation. So that study would be ongoing, and the drug would be available. If the drug became approved, then possibly there would be some kind of, sometimes what I've seen is there are what are called extension studies where you'd end up sort of having some sort of access to the drug through some sort of a mechanism. And sometimes what happens is the company says, okay, great, now that we're done, we'll work on getting this covered by your insurance.
So I guess this sort of goes along with that question, is that if it is approved, the clinical trial required an RCC involvement. But if it was approved, would it be approved solely for patients with RCC, or could it be prescribed off-label?
Right, and so that's the question. That's one of the things that we're going to be working on, would be to, based on the data, because as I mentioned before, 80% of individuals on this trial have hemangioblastomas, right? So we've got some pretty solid data on hemangioblastomas, and in terms of whether it does or does not work. And so one of the hopes again would be that this that in approval would be a broad approval, that it would be for VHL related, maybe it would be renal cell carcinomas and hemangioblastomas. And that's, I think, going to be, that's one of the tricky things, because the primary endpoint of the study, basically, what we formally are testing is shrinkage in the kidney lesions. But obviously, you can't avoid but looking at what's happening elsewhere. And then it's going to be a question of whether the FDA feels that the data are sufficiently good to say, yeah, and we're seeing great responses here, so we're going to change this approval from just kidney cancer related to VHL. And that's again going to come out in the future as the data mature.
For patients who have previously taken other drugs, things like cabozantinib or other medications like that, would that affect their ability to potentially be prescribed PT2977 in the future?
My hope is no. Although everyone that's on this study was what we call treatment naive, meaning they had not received prior therapy. I would, and again, this is me speaking as a advocate for my patients. I would hope that there would not be that type of a statement put in there that they would have to be previously untreated. That's going to be part again of the negotiation, if you will, with the FDA.
Have you or has the research shown any benefit of the medication on pancreatic lesions as well as ELSTs?
Yeah, and so those to be announced. So there isn't anything in the public domain yet regarding that, and that's going to become available in the future.
How does this therapy compare to an immunology therapy? Is one preferable over the other?
Yeah, interesting question. And at this point in time, part of what I'm doing from a research perspective is to try to understand whether immune therapy does provide benefit to individuals with von Hippel-Lindau disease. And that would be, it's done both sort of by observing what happens clinically, just through anecdote, as well as by looking in the lab on tissue to see whether or not there is an immune infiltrate already to begin with. And immune therapy doesn't work in everybody with kidney cancer, nor does it necessarily work in every lesion. So from a side effect perspective, a single agent, meaning one drug, like PD-1 inhibitor, side effect wise, probably be similar to this, but combinations are immediately much worse tolerated. And the effectiveness, again, we don't really have a ton of information right now with regards to immunotherapy in VHL disease. Just anecdotally, what I've seen with individuals who have metastatic kidney cancer from VHL disease, it doesn't seem to work amazingly well.
Going back to side effects, can you speak a little bit more about the side effects, and as well as for people who are experiencing anemia as a side effect, would they have to continue treatments for the anemia as long as they were on the PT-2977?
Yeah, so we've seen that treatment with EPO or erythropoietin, which is basically a shot, works well. Has to be given every once in a while. Seems to manage it. So it's kind of a wait and watch and administer additional EPO as necessary.
Can you speak a little bit about how VHL Alliance awarded research grants have contributed to this major breakthrough?
Yeah, so VHL Alliance has been providing funding for basically early research for over a decade now, and one of the research grants that was awarded in the early days was actually towards Bill Kalin and Othan Iliopoulos to perform research into VHL. So as you guys know, Bill Kalin won the Nobel Prize for his understanding of VHL and HIF-2alpha biology. And so I think we can see a direct link here between supporting innovative, exciting early research and what we are now talking about today.
Can you, I don't know if you can speak to this, but do you have any insight on how approval and access would work for patients outside of the U.S.?
Yeah, I mean, in general, so when compounds are submitted for approval in the U.S., they then there's like in Europe, there's the EMA, there's a separate mechanism for approval Europe-wide, and then sort of at a country-by-country basis then. So this is somewhat of a parallel process usually, but they're independent. Generally speaking, most of the time what we see in the United States ends up then being seen in Europe. With regards to the rest of the world, like Asia, oftentimes in Asia, countries will want to have additional confirmatory studies in their patient groups, in their own patient populations. So we'll see that there it would end up being delayed a little bit. Similarly in South America.
Has there been any indication on how long the benefits of the medication might last, or is there some thought that this would be a medication that a patient would take for the rest of their life?
So at this point in time, our length of follow-up we have is less than the average length of follow-up is sufficiently long that we can say that whoever's been on the drug really has stayed on the drug. But we really need to gather more data over a longer period of time to find out whether or not this is something that's going to be durable. One of the interesting sort of thoughts would be that maybe this would be a drug that one would take for a period of time to shrink things down to the degree that you want them shrunk down, and then you would then take a little break and then start again when things start growing. I mean, there's a lot of different sort of future sort of thoughts with regards to how one would actually use this type of a drug.
Usually, once a pathway is verified, other companies and compounds are attempted. Do you know of any other compounds with a similar pathway that are on the horizon?
So there are other drugs that are trying to interact with HIF-2alpha. There's different ways to do this. One is these like small molecules so basically this is a chemical that has a particular shape that can basically fit into a crevice of HIF-2alpha to prevent it from functioning. So it's literally like thinking like putting a cog in the wheel type of thing, or sorry, stick in the cog. Mixing my metaphors here, but there are other things you can do. You can prevent the production of the HIF-2alpha protein by using what's called small interfering RNAs. So DNA gets turned into RNA, RNA gets turned into protein, and you can then at an RNA level try blocking it. And there are efforts underway to do that. There's a company called Arrowhead. So there are other efforts. In terms of another sort of Me Too compound like MK6042, at this point in time, there isn't one, but who knows? There's imitation is the sincerest form of flattery.
Have you noticed any, or has there been any evidence that patients who have previously had kidney transplants it would be contraindicated?
So as of now, we don't know, but a priori, there wouldn't be a reason why this shouldn't be given in that situation. And that comes, that would be an assessment of the interaction between MK6042 and some of the drugs that might be necessary for immunosuppression. It's a really good question, and one of the questions that we'd probably need to be sort of facing at some point in the future.
And one final question for you, Dr. Jonasch. What can patients do to support your work, support your efforts, and help to encourage the FDA and help to push this through?
I think the community has come together beautifully, I think, with regards to their enthusiasm for this, and I think just demonstrating that in public forums like Facebook and demonstrating that this is something that the community wants is helpful, very, very helpful. In terms of research for VHL, I think supporting research funding so that we can, a lot of very good questions were asked today with regards to what are some of the next questions. And some of those questions can be answered through additional clinical trials, but there is also some additional questions that need to be asked and answered in laboratory research. And this is, I think, really the lifeblood of future innovations in the treatment of VHL disease. So we really need to continue to support that.
And I should also mention that there will be an FDA listening session that the VHL is participating in, separate from Merck, that we're excited to present the patient and family experience. So it's another way that patients and families are helping support the efforts. Dr. Jonasch, thank you again for taking the time to talk to us today, as well as for all the amazing work you're doing in VHL research and supporting the VHL community and all of your patients. We really appreciate it, and we're so thankful.
Thank you, Josh, and thank you everyone for joining, and we'll keep you all posted.
We can't wait. For everybody watching at home, you too can help support VHL research. Please consider participating in the MyVHL Patient Natural History Study at vhl.org/myvhl, where your information can help researchers make new breakthroughs in VHL research. You can also support VHL research financially by making a contribution to the VHL Alliance at vhl.org/donate. We hope you'll join us for future events that you could find at vhl.org/together. Until then, stay safe.